Thank you, sir. Respected Chairperson, thank you, AIOS, for this opportunity. So I'll be speaking on PDR and PVR. So this was actually one of the first few cases which I started operating under 3D visualization system. So I was really skeptical because they said it has a very long learning curve and the peripheral visualization is not there, the lag is not there and everything. So just here you can see it was a very but of PDR with you can see it almost like a tabletop TRD. So thanks to these modern gauge cutters where you can do this segmentation and delamination, most of these with the help of the cutter itself. But when it comes to periphery, I don't think any surgeon hesitates to go bimanual, because you can see the periphery is pretty much sclerotic and very thin and necrotic retina. So I didn't want to take chance with the help of cutter itself. So here you are showing the fold back delamination as described by Steve Charles here, just trying to. So the key here is remove as much as membrane as possible up to the extreme periphery, because they are the chances where we go in for the PVR. Now I'm just removing the next bit of these membranes on this side, and finally after removing most of these membranes, I put a PFO and did a peripheral base shaving and then lasering the edges. Silicone oil was injected and luckily the patient improved 20/80 in this. It's a silicone oil filled eye, so it's a reflexes which came into that. The both eye had a similar picture, but I think she was happy with one surgery and did not agree for the other. So this is the another case of PDR surgery. Now we have shifted using the color filters. So here you can see it's a case of again where you have to do a bimanual surgery in these membranes. So what's the advantage of using these color filters? You saw that the bloody red which was there, it gets reduced. So while you have to do a bimanual segmentation, these membranes, they try to fluoresce. Under that you have to adjust the gamma, hue, saturation, and most of these settings when you do it, you can see these membranes try to get a fluorescent kind of hue. So that definitely helps us in when it is especially mixed with the blood and a thin necrotic retina. So this is how I just wanted to show that how easily we can get through with these bimanual membranes using the various filters. Especially here what I am using is the reduced red filter and the green filter. So again you can make a mix match of whatever best suits your hand. So coming to the next, this is again you can see here this was a case of again a TRD, and I'll just try to forward it. So I just wanted to show it to the fellows or the residents here. It's a good case to show about the segmentation. So how we do the segmentation, it's just simple as the example which was given by my mentor. When you have a bridge, just cut across the bridge, that is the segmentation. And what is delamination? When you just cut across the pillar which is attached to the bridge, that is the delamination. So here I'm just trying to showcase the segmentation with the help of the cutter, and once we segment it, you can do a multiple piece segmentations and then you can do the delamination. So this whole surgery was done with the cutter itself. As you can see here, I have never used a forceps in any of these. So thanks to these 10K cutters with the slight beveled of these the end, so that it acts like a forceps also, and definitely with a good cut rate, cut speed, with a controlled this thing. And now you can see I am just doing a delamination here. So similarly all these the membranes were removed with the help of cutter itself. You can see I'm just, and finally the ILM peeling was done and the air was injected in this case, and this is the post-op picture. The patient had a pretty good visual recovery in this case. So moving to the next PVR cases, extreme gate PVR. So this was a unfortunate boy, 15-year-old, who got hit with twice with football and the tennis ball, unfortunately, and that too within a span of 15 days. So it was almost like a closed funnel. It is a closed funnel RD. And the challenge here was to do the vitrectomy and try to unfold this membrane as much as possible. Now here I am using the light pipe and the cutter to open up that closed funnel RD, and then step by step PFCL injection is very, very important in these kind of cases. And then you know that the peripheral, the traction which is persisting, you have to do the retinectomy, try to remove as much as membranes as possible, the subretinal gliotic bands as much as possible. And here you can see there was a temporary traction still left. So again I had to remove most of these traction, and finally I could see a well settled retina. But after 1 month this was the picture. So I thought it has went into PVR again and it has caused the closed funnel again. So here I could not see the pupil at all. So the membrane was very badly adherent, and you can see even the corneal neovascularization also had started. So I had to do a pupillectomy with the help of the cutter, and surprisingly when I went inside I could see that only the inferior part of the retina was lifted and the silicone oil had gone underneath that part of the retina. So indicating that there was a traction in that area. So I just did a little more retinectomy, and with the help of the fluid air exchange, as you know, silicone oil is lighter than water, it floats. So you can remove the silicone oil easily, and then whatever traction was there was removed, and finally the laser was done, and luckily the patient had around 3/60 kind of vision. So that itself I think is the happiness in the VR surgeon's life, not 6/6 or 6/20 in cataract surgeries. So this is another case, a bad case. As you can see the foreign body here, and with the retinal detachment, with the vitreous hemorrhage. So the altered vitreous hemorrhage was cleared. The challenge here was to remove this foreign body, and I tried to use a MVR blade so that I can use this magnet. So here I tried to remove the foreign body, but it fell down. I tried to remove it with the forceps, again it fell down. So finally I had to use the vectis below, and then with the help of the dialer I had to just squeeze it out. And you can see because of the irregular shape of that foreign body, it was very difficult to remove through the scleral wound. And the next challenge was to settle the RD in this bad cornea, and finally I could get a good view, and you can see the retinal detachment was settling well. And then not just that, even the ILM peeling was also done in this case. So these are the kind of cases where you have to find your way to improve the visualization in these kind of cases. In the interest of time, I think I will. So these are the different kind of surgeries which we did under the 3D visualization. Even in the bad corneas also, we could settle the retina pretty well. This was just a last 30 seconds I'll take, sir. Extremely sorry. So this was a case who was admitted to the blind school. He was a 14-year-old boy. And when we do the yearly blind school follow-up, so this was the case. Almost the retina was seeing behind the lens, as you can see here. So here it's always better to remove as much as possible under the microscope itself before going in for the endo-illumination. So infusion then passed on, and then now you can see the membranes there. So meticulously it has to be peeled, first trying with the periphery, and then try to use the bimanual if required. I'm just fast forwarding it in the interest of time. And then now you can see after the removal of most of these membrane, and here luckily we could remove most of these membranes without doing much retinectomy in this case. So the peripheral barrier laser was done, and the brakes were lasered, and finally the retina was attached well. So thank you very much for the patient.